Welcome to our Systems for Action Research in Progress webinar series. This is an opportunity for everyone to join and listen in about Systems for Action and the research projects that we funded all across the country. We fund projects that test novel strategies that help for helping delivery systems and medical, social, and public services work better together with the goal of advancing equity and population health. This Research in Progress webinar series is a great chance for us to hear from all of the research studies that are being conducted through our program about their experiences and what they're learning about systems alignment so far. Today, we are going to be hearing from our team at CUNY. Their project is titled Multisector Task Sharing to Improve Mental Health in Harlem. And this is their second presentation in the series. I believe they're in their second year of their research project. So we are going to hear some exciting updates about what they've been working on. Thank you for changing the slide. So just to give you an idea of what to expect in our Research in Progress webinar today, we have our welcome, which we're listening to right now, and then we'll have our research team jump in and present to you about the work that they've been doing over the past year and provide you with some important and exciting updates. And then we'll have some commentary about the importance of their research and how it's impacting the community from Dr. Bean. And then we will reserve the last 10 to 15 minutes for Q&A. So if you have any questions at any point during today's webinar, please find the Q&A box at the bottom of your Zoom screen and go ahead and throw your question in there, and we'll save some time at the end to make sure that we answer those. But if any questions come up in the meantime or at any point during today's webinar, make sure that you enter those there. So with that, I think I'm going to go ahead and hand it over to Dr. No so that she can introduce herself and her research team, and they will get started with their presentation.
Great. Thank you, Karen Tin. Hi, everybody. My name is Vicki No. I am a clinical psychologist and PI on this project, and I'm so honored and thrilled to be able to share with you our progress over the past year. I'll be joined by my project directors, Dr. Punter, who's the president of HCCI, and Ms. Deborah Levine, who's the director of the Harlem Health Initiative. I'll pass it on to them for them to introduce themselves, and then we can get started from there. Thanks, everybody, for joining us.
Thank you, Carrington. Thank you, Victoria. I'm happy to be here. As stated, my name is Malcolm Punter. I serve as the President and Chief Executive Officer of Harlem Congregations for Community Improvement, HCCI. This organization was created in 1986 by clergy, men and women, with the goal of revitalizing the Harlem community, which had deteriorated in terms of its housing stock, its health and wellness services, and became, crime-ridden due to the introduction of crack cocaine as well as a heroin epidemic during the late 1960s, 70s, and 80s. HCCI systematically began to work with public and private partners to reclaim many of the housing buildings and rehabilitate those buildings and place them back in services for low, very low, and moderate income households. However, we learned very early on in our tenure that we needed to provide wraparound services, including health and wellness services. We started our health and wellness strategies division early on, established in 1995, and with the hope of helping people that were living with HIV and AIDS at the time. And this was a novel concept. You'll learn more about HCCI as we discuss this program and our study and our research and how we're helping individuals in our community. But I'll stop there for now and look forward to discussing further with you and learning more. Deborah?
Thank you, Dr. Punter and all. It's a pleasure. My name is Deborah Levine. I'm the director of the Harlem Health Initiative for the Graduate School of Public Health and Health Policy, and it is truly an honor to be able to be the bridge between our community and our academic institution. Thank you. Dr. No?
I'll pass it on. Next person is Marina.
Hi, everyone. It's such an honor to be here in this group of people who are interested in thinking about how to make our systems work better for our communities. I'm really interested in joining in that work as well. I'm a postdoctoral fellow under Dr. No, at the Center for Innovation in Mental Health at the Graduate School of Public Health and Health Policy at CUNY. And I will pass it to Dr. Bean to introduce herself.
Oh, she might not have joined yet since she's in another meeting. Right?
Well, we can bring her back in when she does join. So I'll pass it back to you.
Great. We'll pass it actually back to Deborah, who's going to talk a little bit about the history of our collaboration and how we're funded.
So just really briefly, as you can see here, we've been fortunate enough to receive funding from the Robert Wood Johnson, from NIH, and from the CUNY Interdisciplinary Research Grant Team. What I will say is that this work really started about 3 years ago, when we had no funding, and this was really a conversation that Dr. Punter and I started about the concern for community residents in the beginning of COVID around anxiety and depression, which quickly blossomed into a conversation and concern about the staff who at the early part of this pandemic, not only were dealing with the issues and concerns of the consumers they were serving in the community, but had their own issues to deal with around death and dying, around the unknown, and about just dealing with the pressures of COVID and sort of the unknown. Dr. Punter allowed me to share that conversation with other executive directors and primary care physicians in the community. And what came super clear to us was that the conversation around anxiety and depression a lot of times was being masked by things like folks saying, oh, I could just be resilient. I'll just work my way through it. I'll push through. But we really started to see more of the cracks in our community about the impact that anxiety and depression was having and the stigma that was attached to asking for help. So that quickly afforded us the opportunity to have a conversation with Dr. No and others, and birth the idea of Harlem Strong. And if you would go to the next slide, please. This is just a sampling of who answered that call. Everything from academic institutions to our government partners, including the Manhattan Borough President's Office, our elected officials, community-based organizations, our houses of worship, and most of all, our Healthfirst providers stepped up to say that they were interested in having a larger conversation around anxiety and depression, and felt that an initiative like Harlem Strong and building out a coalition would be critical, not only to supporting the community residents, but also undergirding and strengthening our community providers. I don't need to tell you that through COVID, you would imagine that we had deficits before COVID. COVID has just pulled back the covers and shown us more about where the gaps in services are. I'm super excited that we have our federally qualified health centers with us, our community-based organizations, but most of all, it's the trust of the community. And just want to take the opportunity to thank both Dr. Bean and Dr. Punter for trusting us to work in the community to implement such a critical activity. Next slide. So I will turn this over to Dr. Punter.
Dr. Punter, you're muted.
Thank you, Deborah, and thank you all for being here. The Harlem Congregation for Community Improvement, otherwise known as HCCI, has enjoyed a distinct and trusted partnership with the residents of the Harlem community for over 38 years. But by extension, because HCCI was created by the churches and other houses of worship in the community, their influence has been remarkable, and it has been our responsibility to try to revitalize the Harlem community. And just so you can get a perspective on the density of the Harlem community, there are about 250,000 residents that live in what we traditionally call Greater Harlem, which makes it a very densely populated environment. And as you can imagine, that population rivals many of the larger cities throughout the United States. The other characteristic of the Harlem community is that it's always, at least since the early 1900s, been majority of the residents were African American or Black, African descent, and Latinos, which happened to correspond with the lower income strata of our population in New York City. So, you know, the needs of the community have been, you know, varied and very long standing. So in the early 1980s, we found situations where the environment consisted of almost 23,000 abandoned buildings, vacant lots, and underutilizing city-owned spaces. And there was food deserts, as well as economic and bank deserts in the community. And there's been correlations in research that says mental health is affected by, you know, people's circumstances in their environment, particularly poverty. So, you know, what I like to mention today is that, you know, the coalition and the partnership with the School of Public Health and HCCI, an organization like HCCI and many other organizations, was essential, particularly during the advent of the coronavirus, which really took you know, caused us to take a real look at the health systems and the disparities in the health system. HCCI, for example, employs caseworkers and social workers, and what they've been confronted with for many, many years, anecdotally, has now been something that we've been able to research and prove in our formative studies. So we know that the COVID-19 you know, exacerbated and magnified mental health issues and inequalities in mental health in the Black and Latino communities. While we knew anecdotally that Black and Latinos, you know, had a higher death rate on other debilitating diseases, but certainly this has proved true as it relates to COVID-19. And you can imagine, you know, when people are impoverished, they may experience, you know, other mental health issues. But our study found that the, you know, depression and anxiety rates increased from 30 to 56%, and they were higher for the Black and the Latino communities compared to white Americans. And then low income, you know, individuals were 7 times the rate of depression as for low income individuals as opposed to high income individuals. You know, this was a staggering finding, even though we had the feeling that this was happening because we work with people day to day. That means that the health system and the social determinants and mental health, you know, issue disparate and working together, which created system challenges. You know, I'll give you examples, real life examples. We had residents in our buildings. We were actually responsible for over 100 residential buildings for low income residents. And you know, landlords are traditionally unprepared to work with tenants' social and mental and health issues. We're strictly providing shelter, and that really presents a problem for the community as well as people and organizations that intend to do well. That means that there's some systematic challenges, and we found, for example, there was a lack of mental health capacity and knowledge amongst our own staff in our group, but generally throughout the community, particularly in low and ethnic minority communities. There was also fragmentation that we've discovered. Now, systems and departments and healthcare systems were not communicating with each other, and organizations didn't know who to refer to. And so that means that referral systems were failing. And also that community-based organizations were simply not funded and prepared to provide mental health services to their constituents. financing and challenges continue. So, if we state the problem, quite distinctly, there was limited access to healthcare services and system fragmentation, structural racism, lack of resources, investment in low-income ethnic minorities. Housing is just not enough. What we discovered, the possible solutions are, making sure that there's engagement, community engagement, and partnering. That any resources and strategies must be culturally responsive and social justice oriented. And it must be a multi-sectoral design and plan that builds the capacity for the system that needs to be coordinated for the people that we intend to serve. And including community-wide collaborative care models and including integrating housing developments, primary care, community and faith-based organization, and certainly the houses of worship. What we believe is that that strategy is best implemented when we share the task, train individuals, train our social workers, our caseworkers, our community health workers, our clergy, and our governmental entities how to refer appropriately, so that the system won't continue to break down. Next slide. Next slide, I'll pass this on to Marina.
Yeah, so thank you so much, Dr. Punter, for that explanation of the things that folks were facing in our Harlem communities. We recognized the need for these kinds of solutions that centered community and their needs and built solutions around their needs. So we began this process by creating a coalition of community members and organizations to increase community engagement in the questions about what needed to be innovated, what needed to be transformed, and what would be sustainable in terms of integrating mental health more significantly within Harlem. Then we asked that coalition how to tailor the mental health integration models that we were using to identify barriers, facilitators, and preferences specific to Harlem's service needs and implementation strategies that would be exciting and feasible for them. Then we are working on aim 3, which is figuring out what actually works in our communities and developing and testing our implementation strategies for a multi-sector community care model delivered in 2 different settings, both in low-income housing and also in primary care. Next slide, please. Within our coalition, we have 3 different groups. We have our community advisory board that consists of folks who meet with us and give us advice about how to structure the program. And then we also have community stakeholder planning council meetings. And those are meetings with general community members who are interested in contributing thoughts and ideas to how mental health can be best integrated to make it feasible and tolerable, as well as successful and sustainable for Harlem community members. They provided feedback on many different elements of our work, including our training programs, our toolkit, the plans that we have to implement our programs, and the components of each of our projects. And additionally, we also hold community implementation planning meetings where we discuss things with key stakeholders to integrate additional community feedback. So we're really trying to make this a process that is led by community and informed by community insight and community needs. Next slide, please. So we've accomplished a lot in the first year of this work, and a lot of this is really a credit to Dr. Punter and Deborah and Dr. No, that so much has been accomplished, because this is a very, as many of you probably know, community-based participatory research is a very long process, but we have met with the community multiple times to get feedback from community leaders through our CAB and also from consumers of mental health several times through our CSPC Community Stakeholder Planning Council meeting. So this is just a summary of that. Next slide, please. We also conducted a needs assessment within consumers and other residents of Harlem. And basically what we saw was that many folks were at risk for mental health concerns. And that was defined as having a depression score of 3 out of 6 on the PHQ-9, or an anxiety score of 3 or greater out of 6 on the GAD-7. We also looked at PTSD risk, which was endorsing 2 or more symptoms of PTSD. So overall, over 60% of participants, as you can see, screened positive for some kind of mental health risk across those 3 categories. And that's just a really significant percentage of folks, since we know that folks tend to minimize and deny these kinds of mental health concerns, as Deborah was mentioning earlier. So this number is probably even higher if we actually sat down with folks rather than having them complete an online survey. And we also saw that significant folks were endorsing moderate or severe depression severity, which was also concerning to us. But this really suggested that folks in Harlem do need this kind of mental health integration intervention. Next slide, please. Additionally, we saw that there was significant association between certain psychosocial risks and those previous findings about mental health risks. So folks who were indicating that they had housing insecurity or food insecurity were much more likely to indicate that they also had mental health risks, which makes sense to all of us who are scientists, right, who work with folks. But I think it is also really imperative to our model that we also include issues to address those fundamental concerns, which can cause, understandably, anxiety and depression, right? Also, we saw that a significant number of folks were reporting interpersonal violence in their homes, and that endorsement of interpersonal violence exposure was also correlated with anxiety and depression and trauma symptomatology, unsurprisingly. We also saw that there were significant associations between substance use and mental health risks, which we understand can be the result of self-medication or other kinds of attempts to manage one's mental health concerns with those feelings, or low self-esteem as a result of feeling really trapped by substance use. We also saw that ever having been positive for COVID was associated with greater risk for mental health concerns, which leads to some really interesting research questions. We also asked, because members of our team are interested in more social factors such as social cohesion and trust, we saw that folks who were experiencing anxiety, depression, and trauma symptomatology showed significantly higher rates of disintegration of their social cohesion and trust, so really lacking that sense of belonging and community. And we also saw that having negative perceptions about the police and feeling unsafe because of the presence of the police in our communities was also significantly associated with increased mental health risks. So suggesting that there may be mental health risks to those exposures as well. Next slide, please. Additional findings from our needs assessment survey showed that alcohol misuse was specifically associated with mental health risks. You can see from the asterisk that many of these factors, affordable versus NYCHA market rate housing. So folks who were in our public housing, which here in New York City we call NYCHA, or in affordable housing, which was subsidized by other organizations, were more significantly likely to have mental health risks. That's again suggesting that socioeconomic factors are really driving some of the mental health risks in our communities. Additionally, alcohol misuse, food insecurity in particular, interpersonal violence exposure, and having ever experienced discrimination, as well as feeling negative about the police. So these are just the 95% confidence intervals for folks who might be interested in those. Next slide, please. So we also saw results around mental health service need, usage, and satisfaction. Overall, we saw that only a few of these were significant. In terms of the mental health services used, folks who are using anonymous online counseling and therapy services showed a significant relationship with mental health outcomes. Additionally, folks who are receiving text-based support. So this is suggesting that folks were interested in receiving additional support, and a lot of folks are reporting using a lot of different kinds of services, which is interesting, but also indicative of the fact that there just aren't enough in-person resources in the communities that we serve. Next slide, please. So additionally, we wanted to just highlight this finding about housing because this is an important component of the intersectional stressors that our communities face. In addition to facing mental health concerns, our communities also face significant discrimination around housing and historical factors that lead to disparities in access to housing, such as systemic racism, and other socioeconomic structuring factors. So we see the blue bar is the total. The red bar is quote unquote typical housing, meaning they're paying market rate rent or they've purchased their home at a market rate price. And then the green bar is our affordable housing, or again, government subsidized, because the person is lower income. So folks who were in those affordable housing categories reported slightly less medication use and psychological service receipt and psychological support need. But overall, very similar across those three groups in terms of their actual use of care, which is interesting as well and points to, again, what Dr. Punter was mentioning about the services desert in certain regards in Harlem, that like even folks who potentially own their own home or are paying market rate rent don't access mental health care at higher rates, suggesting that there is a shortage of mental health care. Next slide, please. So we heard in our community stakeholder planning meetings that there were a lot of factors that prevented folks from accessing mental health care, and these are some of them. There were a lot of feelings that, for example, systematic oppression was a concern when seeking mental health care, that they would be experiencing racism, there would be financial pressure to focus on other financial priorities rather than spending money on healthcare, as well as a lot of concerns about whether caregivers or mental health providers would be aware of the issues specific to minoritized groups like racial and ethnic minorities like Black and Brown folks in Harlem. So thinking about these factors, we wanted to create an intervention that would address some of these concerns. So overall, next slide, please. Overall, we identified from our community stakeholder planning meetings needs and opportunities across several domains. The first is consumers. They indicated that they have challenges in terms of seeking out and receiving mental health care, and also in terms of the stigma of mental illness, both in terms of external stigma and internalized stigma, having difficulty admitting that one might need mental health care or might benefit from those kinds of supports. So we also discussed with them some opportunities, including integration of mental health supports across multiple organizations to make it easier for them to get connected to those services, and community-wide mental health promotion to attempt to move the needle a little bit in terms of the culture of stigma of mental illness. Within the domain of intake and screening, they reported there weren't challenges because folks were not currently doing mental health screening very much. However, screenings to improve access to care for organizations that use them could be a need. So we saw that as an opportunity to train and support more routine use of anxiety and depression screening. Additionally, they reported that folks who aren't in immediate crisis fall through the cracks because, as we know, there's very little preventative mental health care in our country, in our city, in the neighborhood of Harlem in particular. There's often only reactive mental health care when someone's fully in crisis, and not support along the way to prevent and support that person before they get to that crisis state. So that's also an opportunity for us to think about, how we can identify when somebody is mildly struggling and how we can intervene before that gets out of hand. Within the domain of services and resources, one of the challenges is the lack of training, as well as the lack of infrastructure in terms of human resources, technology constraints, and communication challenges. And that represents an opportunity to share resources among organizations, because we know that there are organizations that have training and infrastructure to address these kinds of challenges, and to create more awareness about services across the system, to create that network of folks who can provide that support. Within the domain of referrals, we saw that there were very few places where folks were going to get their mental health care. They were all going to the same mental health resources. That included NYC Well, which is our free citywide mental health support, the mayor's office, which provides very supports for initiatives and community mental health, and that those services had very long wait lists. So we saw that as an opportunity to think about providing those services again across a range of organizations to provide lower level preventative services, and also to identify folks who needed additional services and pass them on to those more significant mental health services as needed to ease up that bottleneck. And then within the domain of follow-up and coordination, there were some challenges identified about meeting the needs of special needs or high need populations, such as folks who were severely mentally ill or had developmental delays. And we also saw that there was poor coordination of care. So often folks would get a referral and then they wouldn't be able to make the referral appointment for some reason, and they would just fall out of the system. They would no longer be receiving care, and there was no one who was looking out for them and helping them manage themselves to get a new appointment. So we saw that as an opportunity to need a new model of care with a more individualized and tailored approach. So next slide, please. Within the challenges that we identified, there were several important barriers to care that I've mentioned. One included inadequate staff education and training on mental health and counseling. Another is the stigma of mental health. And the third is limitations to the ways that services were offered, right? Services were just offered as a one-time appointment. If you miss that appointment, no one's following up with you, or there's a very long wait list to get to that appointment, or there's no incentives for providers to refer to each other or coordinate about like, hey, Mr. Smith didn't make it to his appointment today. Who can I call to reach out to make sure he's okay, or to try to get him a new one, right? So the lack of accountability, the lack of a network, the lack of a team-based approach, and the significant concerns about the ways in which folks were falling through the cracks were considerable. Additionally, we saw that there was concern about provider burnout for those few providers who were seeing a lot of the cases, as well as some tech issues around capacity to manage the volume of cases those folks were seeing. So next slide, please. Here are some of the actions that we heard from our CSPC that we wanted to bring into our implementation plan. And so here's I'll go over each action idea and then talk about where it's implemented. So within the domain of coalition building and coordination, we wanted to create an opportunity for decision makers, policymakers, researchers, and providers to hear more directly from folks who are on the ground. We wanted to find folks who could make change in the system and be the voice of folks on the ground in that way. And we also wanted to make sure that we were triaging folks' needs so that we were addressing the needs of those who were most in need, and create a network so that there's an interagency data sharing agreement that allows folks to share those pieces of information. Hey, Mr. Smith didn't make it to his appointment today. No worries. I can reach out to him and make sure that we follow up about that, right? So instituting data sharing was also key. Additionally, we wanted to increase access to services. So we're creating our multi-sectoral model of care, which includes mental health task sharing and a stepped care process to increase folks' access to care in the communities. We also are increasing mental health outreach and hiring and retention of qualified staff to perform those mental health task sharing roles. Additionally, there's going to be increased telehealth and telecommunication support to make sure that folks get connected to the services they need. And I'll also just mention really briefly that there were a lot of different topics that were mentioned within our discussions with the community stakeholders, and we incorporated a lot of their priorities into our online trainings for those mental health task sharing teams so that we can make sure that the things that the community wants to hear more about and have incorporated into this model are really represented. And we're making sure that we're addressing the issues that they feel are most pressing. And I'll pass it to Dr. No for discussion of the intervention.
Thank you, Marina. And thank you, everybody, for being here. And so as you've heard from Marina, we did a significant amount of work to better understand the challenges, the needs, and the solutions that would be feasible in the community. And with that, we use that to inform the way we develop our program. And so, what we're doing is we're expanding the collaborative care model, which has traditionally been a model where you integrate mental health or any other kind of specialized service into primary care. What we've done is we've expanded it from primary care to also include housing, because in Harlem, that would be another important gateway to reach more individuals in Harlem. And so this model represents a team-based approach where we're connecting housing and primary care and expanding it into the larger coalition of organizations in Harlem. And specifically, we are training navigators to help support mental health promotion in the community, screening and psychosocial assessments, which includes screening for depression and anxiety, as well as screening for severe mental illness, so that they can refer those individuals to more specialized care in the mental health system. And then the psychosocial assessment is really to help the navigators understand the needs of the individual so that they can appropriately refer them to social services if needed, and any other additional supports. We also train them on psychoeducation so that the consumers can be more informed about what they're struggling with, as well as the resources available in the community. We will be providing some basic brief counseling skills training focused on stress management and wellness, because we want it to be practical. We want it to be short term, given the high volume of consumers that may be needing help in the community. And so, and this is something that, that could actually benefit everyone. You don't really, it's not necessary to have a clinical condition. This is more around prevention and early intervention. And then lastly, we focus on referrals, because that's so important. There's a huge break in the linkage to care. The referral process is basically not functional these days. It takes 3 to 4 months to get an appointment for mental health service. Referrals are made, no one knows what happens to them. And so that's the reason why we focus on navigators for them to follow up on these referrals, to ensure that, the referrals are successful. And in terms of who we're involving in, as navigators, it's actually quite broad. In some cases, like in primary care, navigators may be the nurses, it may be a case manager, it may be a community health worker. In housing at HCCI, there are social workers, there are also case managers, but there are also others who may be like housing coordinators can serve in that role as well. And so it's actually a broad group of folks that will be training to be navigators, and they will receive additional support and coaching from us to serve in that role. And they'll be the main coordinator of the service. So now let me talk about the 3 conditions. Our research questions are focused on both the effectiveness of the MCC model, but also the implementation strategies. And so what we're doing is we are randomizing groups to education and resources, which is, the training on how to do MCC, but without the network. And so, we anticipate that they'll be hopefully engaging in mental task sharing through that. But they won't have the support for, from the network. The MCC condition is our primary condition, and that is one where the navigators are situated in housing and primary care, and they're connecting folks across the network. And so they'll have exposure to the coalition and the planning that happens through the network. And we believe that with the network, we're going to have better adoption of mental health task sharing, and we'll also have better, we'll have a more successful referral process, and have successful linkage to care and close that gap. The third condition is our technology condition, and that's a condition that gets added on after 2 years of the program. Next slide, please. And as you've heard from Marina, there were a number of challenges, and from Dr. Punter, challenges at the system level across, both the larger system as well as within organizations as well. There's fragmentation of services. There's also lack of communication, so there's a variety of different system challenges. And given that, we needed to have a variety of different implementation strategies. First is the Community Advisory Board, which is made up of leaders and other community stakeholders to help us think about solutions at the system level. And then we have the coalition, who's also helping us to better engage the network of organizations in the community. And so that addresses the community level, the societal level, and the organization level. We will also have an electronic hub to make all of these resources more accessible to the community. We will also be offering hybrid training, which includes online training modules and then webinars, which will be live, and then in-person workshops. We will also have coaching and a learning collaborative to create a community of practice. And that's really to build capacity at the organizational level. And lastly, we'll be introducing potentially client management or other forms of data sharing as part of our technology innovation in the third year. And so, we need all of these different strategies to be able to address the syndemics of mental health, social risk, and, in the face of the aftermath of COVID-19. So this is actually, a multi-sectoral, multi-level intervention that addresses both the clinical issues, at the person level, but also the organizational, community, and societal levels. Next slide, please. So for our research, we actually changed our research from a SMART design to a step wedge cluster randomized control study over the course of this year, mostly in response to the community needs about randomization and wanting everybody to have all resources. And so the step wedge design allows us to make those resources available to all organizations involved in the program, and they'll be randomized into the MCC, into the conditions at different sequences. We will have 20 sites that will be gateway sites where we'll be collecting data on the consumers. We will also be enrolling providers to understand, the impact of the training and the network on providers. This will be a hybrid implementation effectiveness study, which basically means we're looking at both the effectiveness of the intervention for consumers and looking at the implementation strategies for the system and the providers. In terms of our outcomes, our main outcome for consumer is looking at the impact of the program on their depression and anxiety. And then in terms of the implementation outcome, we're interested in seeing if the MCC condition increases the reach of mental health services into the community. And then secondarily, we'll be looking at functioning, well-being, social risk, and adoption of services. This is also going to be a mixed method study. So we'll have provider survey over time, 0, 6, 12, 24 months, consumer surveys at 3 time points, 0, 6, and 12. And then we'll be looking at implementation data, which will consist of basically the program data, like the screening, the number of folks who actually receive services, number of folks who get referrals and get connected to care. And then we'll be doing qualitative interviews of the providers and consumers at the end of the project. We've made a lot of progress. We've almost done with site recruitment. We've completed the housing site recruitments. We have 2 organizations that will be involved, which will include 15 clustered sites. And then in primary care, we are recruiting 5, and we have 2 that are enrolled. We're in conversation with 6 who are interested, but it's taking us a little bit of time to get them on board. And I think largely because there's just so much demand on providers' time. So there's significant staff burden right now. And it's really challenging for them to engage in additional trainings or additional activities. And so, one of the nice things about the step wedge design is it allows us to do things in phases. So we'll, have folks start at a later time point. And then in terms of our coalition sites, we've engaged 76 organizations. They're made up of 29 community-based organizations, 13 primary care and behavioral health providers, 8 government assembly person type members, and then we have 5 faith-based organizations involved at this time. And that group will be expanding because that will continue to evolve over the course of the project. Next slide. There's been a lot of accomplishments over the past year, and including a lot of dissemination work. We've presented 4 talks at APHA this past year, and a poster by a student. We also presented at the RWJ Relevant Conference about collaborations and lessons learned from our collaborative work. We are doing a panel of consumer providers along with our core team at the NISTIC Population Health Summit in June. We've had 7 community board meetings. One thing that's really great about this project is that we've been routinely updating the community on our progress. And so we've already had 7 community board meetings. We've presented with community partners and at community partner events. We've had 5 over the past year. We've also, in collaboration with Healthfirst, contributed to 2 town hall meetings. And that's primarily made up of primary care providers and community-based organizations. That's part of the Healthfirst network of care. And we've submitted 1 paper, and we're working on multiple papers actually at this time. And so there's been a lot of progress over the past year. So that's been really exciting for us. Next slide. Also, another really wonderful achievement is that HCCI submitted an application for the CHESI program, which is part of NIH's Compass initiative, which is a community-led initiative focused on funding community organizations to lead research, and it's funded at a level of 12 million over the course of 10 years, which is the largest initiative, largest grant initiative, I think, at NIH in terms of what's available for community organizations to lead. So that's been really exciting. And we've made a lot of progress in terms of our intervention development. We've created the training curriculum and are putting it up on the online training platform that we're doing. We also have a website now, and so the link to the website is there, and that website is going to host a lot of the information for our community partners and host the training portal as well. And we are launching the coalition today in the next 2 hours, or at 1 o'clock. So we're looking forward to that, and we will we'll continue to update the RWJ network on our progress and lessons learned. Thank you. Next slide. Yeah, thank you. And I'll pass it on now to Dr. Bean, who will talk a little bit about the implications of this work and what it means for the system.
Sure. Thank you so much, Dr. No. Thank you to all of my colleagues who are on the call. I'm really excited about this project. I continue to be excited. And I think it's because when we came to Dr. No and to Deborah Levine and just said, we're very concerned during and after the pandemic that our many communities who already were somewhat lacking in connected care would be even more disconnected, and mental health was at the top of our list. And we knew that there had been work in other countries and other regions of the country around not just recovering after, say, a disaster or a pandemic, but coming out better than you went in. So the fact that this was possible for Harlem, a community that Healthfirst Managed Care plan serves, along with others, in a very deep and broad way, was extremely important for us. I think that Marina raised something which she called fundamental concerns. And, this is the part of this project that involves all stakeholders in expressing their fundamental concerns. Not only their concerns, but their priorities and their goals. From the healthcare delivery sector and the managed care perspective, I would say that our concern is really around fundamental care. Fundamentally, we believe that not only our members, but their families, friends, and communities deserve to feel that they fundamentally can have connected care in all aspects of their health. This project is important because it steps outside of the traditional institutional setting where we all know that we're fighting racism and all the other kinds of isms that are impacting communities. And it basically says to the community, you have power, you have tools. Let us build on your power, your agency, and let's take back this community for mental health and emotional health. And from our perspective, that's a gateway to improve longevity and improve quality of care. So we are very grateful to be allowed to contribute our network of providers to this coalition and to the advisory and also in service delivery, because we believe that the overall outcomes here will be beyond just the many, many, many domains of outcomes that you just saw Dr. No describe, but to the successes that Dr. Punter described, but it will actually mean that people who live in this community, the community of Harlem, will experience longer life with better quality. I feel like adding technology to this is critical as well. So I continue to look forward to actively participating in this project. And thank you to all my colleagues who allowed Healthfirst to be a part.
Thank you, Dr. Bean. So maybe we can turn to questions now.
Thank you so much to your entire team for providing us with an update on what's been going on for the past year since we first heard from you and your research team. And thanks for providing commentary, Dr. Bean. I appreciate you joining. So we have reached the questions Q&A section. So if you have any questions, now is your time to go ahead and enter those into the Q&A box. If we don't have time to ask all of these to our research team, we can make sure that they have these questions in hand and they can reach out to you to respond to those after today's session. So I'm going to start with a question that came in about replicating these kinds of strategies. So this question is, if communities wanted to replicate this strategy, what would be a range estimate of cost to start at a preliminary level and build up? And I'll also add on to this, I'm just curious if you have any recommendations for other communities that would like to replicate a strategy like this.
I can't really speak to the cost yet because we don't have the costing of this kind of work. But, you know, I think one thing that's really important about implementation science research is that we document what the strategies are and how much are people getting of those strategies. So we're going to be doing that in this project so that we can, you know, share that so that it will be easier for folks to know exactly, you know, what was delivered and how we delivered it. And hopefully that would allow for better replication as well, because that's really missing in the field, is there just isn't enough, you know, enough documentation and enough description of how things were done. And so that's one of the goals of this project.
Thank you. Moving on to our next question. Has the research team planned to leverage any implementation science methods for ongoing monitoring and manage of the initiative?
In terms of methods, we're using a lot of different types of methods. You know, we have, you know, we're going to be tracking the outcomes, you know, using client management tools. So that, you know, that's going to be one of the pieces of the technology introduction that will be introduced in year 3. We are also going to be using a variety of different strategies, such as the learning collaborative, and you know that would also be tracked as well. The coalition. So in terms of, you know, implementation strategies, those are some of the key implementation strategies. In terms of methods, I don't know if you're talking about, you know, thinking about the REAIM framework or the CFR and, you know, the frameworks, implementation science frameworks. If so, then yes, we are using REAIM to help us think, you know, we're actually using it as a measurement model to think about reach and adoption and quality of service or quality of implementation. And, you know, looking at the impact of those outcomes. And then in terms of the CFR, which is, you know, a model that really helps us kind of organize all the different factors, the organizational factors, the internal factors, and so we're using that to sort of structure the things that we are documenting and capturing, as well as the outcomes. So those two frameworks are going to be informing our work.
Great, thank you. Ruth, I hope that answered your question. We have a question here about training that was provided to members of the collaborative to extend prevention and early intervention reach. Did you train others, like maybe faith leaders or parents or others in the community?
Yeah, so the project is getting launched today, and our plan, our focus is really on the broad network, right? And we have a more focused training on the navigators. So then everybody will get training on all of the mental health task sharing skills in terms of what's available online. The navigators will get additional support, coaching, the learning collaborative. And they're primarily going to be coming out of housing and primary care, but we will also open it up to the rest of the coalition. So if, they have navigators that want additional training, and we welcome those in faith-based, we welcome those that are in any other type of organization. So that, that will be determined based on the need and the interest. And that's another thing that makes this very community informed and community responsive is it really is dependent on what people are interested in and who is interested.
Thank you. So there are a couple of questions that have come in about maternal mental health and questions about how this is being addressed or if it's being addressed in your research.
Unfortunately, we're not focused on like specific populations at this time. That could be a later phase depending on the needs. We've had a lot of interest in youth mental health, in senior mental health, and so or older adult, mental health for older adults. And so, what we're trying to do is find different ways to accommodate those needs. The primary focus of this project at this time is not that, but we'll be introducing those conversations through the coalition.
Thank you. We have a question here about IT. So David says, good for you for leading people and putting IT second. When you do introduce IT, are you looking for a traditional social health information exchange, or are you building software to support relationships between clients, members, and their navigators?
We don't know that yet. I think what we want to do is spend a year implementing and see where those challenges are. And we're also now exploring what solutions already exist in the community. Healthfirst has been kind, to share with us some of the solutions they already have. And so, those are all solutions we're considering at this time. And we'll make them more routinely available through the network, depending on whatever the needs are. So once we start implementing, we'll have a better sense.
Maybe during your next research in progress webinar, you can answer that.
Yeah.
Let's see. I think we have time for maybe one more question, and then we have a couple announcements, and then we'll end our session here today. But let's see here. Question from Robert: is there specific consideration of the SPMI population and integration of behavioral health and medical health within this larger overall effort?
I'm sorry, I didn't understand SPMI. What does that stand for?
The seriously and persistently mentally ill. This project is, as Dr. No said, starting with some of the mood disorders that we know our communities are facing. We are, however, building an infrastructure that I'm very hopeful can, in future phases, lend itself to bringing in all kinds of populations with struggles around accessing mental health services.
Thank you, Dr.
Okay, so we have 1 more minute left. Thank you so much for the research team for joining us today and giving us some updates. I really appreciate it. I know y'all are very busy with your coalition launch and everything else that's going on. So thank you. And next slide. For everyone that's with us today, I think you can hit next slide again. Thank you. For everyone that's with us today, we do offer certificates of completion. So if you're interested in one of these, a survey will pop up and you can indicate that you would like one, and we will send it to you in a timely manner. And then next slide. So this is an ongoing research in progress webinar series. You can hit next again. We do have one coming up on April 5th. Looks like we have stopped sharing screen. There we go. So we have one coming up on April 5th from the National Collaborative for Health Equity. They're going to be talking about the Truth, Racial Healing, and Transformation Framework, which was funded by the Kellogg Foundation. And we will make sure to send you more information about this in our follow-up email, which will also include the slides and recording from today. But we hope you're able to join us for that special session on April 5th. And next slide, please. And that is all we have today. Thank you so much for joining, and I hope everyone has a wonderful rest of their day.
Thank you.